One of the things that I will do, this isn't a webinar. Your video is the one that people. You do want your camera on though. All right. I'm about to let people in. We should have, there are about 150 people who signed up. It might go up from there. You know, certainly it can go down as people's days get to what they're going to be. I'm just admitting in Richard, so I have him, and then I'll do the admit all. It will take a few moments for people to join us, and there will be folks who are let in after we get started. So I just want to make sure I say that out loud. In the chat after we do the round of questions that you all got in the. So you just need to start your video. There you are. All right. There you go. All right. I'm letting in people now. I'm going to hit the admit all. It will take some time for folks to do it.
Hi, Liz. Doctor, there you go. Albert, Dr. Albert.
What's up?
And take a few moments to. Please mute their line to make sure that we are listening to the panelists. You're able to control your mute button by hovering over your own picture and also in the bottom left-hand corner. All right. Be a few more moments just to allow folks to join us. We have about 70 folks on, a little over 70 folks now. We'll probably get some more as we go. So it'll just be a little while longer and then we'll get started. Great. All right, we're going to keep letting people in as we go, but I do want to get us started. We have a short time, but a good time, and I want to make sure that we use make the best use of it. I'm going to ask Richard Harding to do our welcome and kind of our purposing.
So first of all, thank you all. Thank you to everybody who joined in and all of our extraordinary panelists. I'm Richard Harding from the Men's Health League, Cambridge Public Health Department. And tonight, the reason we want to have you with us is to talk about the pandemic COVID-19, particularly how it affects communities of color in both Boston and Cambridge. We're trying to, one, get an understanding of why this hit communities of color disproportionately, and all of the data that shows that across the country, Cambridge and Boston is not immune to what had happened in terms of the disparity of who was affected by COVID-19. But we also want to dig a little deeper and look at some data and really examine, what it is that made our folks of color as a group hit harder, and also looking over the mountaintop or the hill to really think about how we can make ourselves as community of colors more resilient moving forward. We have a deep group of panelists who will talk about their learned experience and their understanding of this from their profession, and also a survivor, Representative Miranda, who will talk about her experience. So I look forward to the conversation, and I'm very hopeful that one thing we could do is make this relevant to the people that we serve in our profession, the people that we live with, our families, and also folks that would be in the space where we could speak about COVID-19 as it relates to setting policy moving forward for communities of color. So thank you, thank you, thank you. And with that, I'll turn it back to Mo.
All right, thank you all very much. I'm going to share my screen so that we can look at a few introductory slides to give us a sense and a shape of what the problem is, and then I will return with an introduction of the panelists. Richard Harding is going to be our moderator, and so he'll be doing a few rounds of questions with the panel. Then we will have an opportunity to take questions from the chat. If you have a question, please post it in the chat. If you have questions about the data as well, please post them in the chat. We can answer some of those along the way. And then we'll have some closing remarks from Congresswoman Ayanna Pressley. Please make sure that your device is on mute, and we'll get started. So welcome, my name is Mo Barbosa. I serve as Director of Community Engagement at Health Resources in Action. The hat I wear tonight is that of the Chairman of the Men of Color Task Force in the city of Cambridge. We are really proud to bring together this group of community members and experts, and also to be able to have this conversation and help people have a better understanding of what this disease has done in our communities and what they can do to stay safe. First, some ground rules, all right? As a public health person, I have to always put in front of you some public health information. So on the right-hand side is some just encouragement about washing our hands. Those of you who are looking at this will see that it says at least 12 times a day, which seems like a lot, but if you think about how often you eat something, go to the bathroom, take a shower, all of those things, it adds up pretty quickly. Just another way for us to take care of ourselves and also to take care of each other. For tonight's conversation, the ground rules are on the left-hand side. I'm going to ask for your patience. We are doing this virtually and not in person, so many things can go awry. I'm going to ask for some flexibility. We have a plan for what we're doing, but we will shift as we need to. I'm going to ask for your grace. Give yourself some grace, give our panelists some grace, and please share that grace with me, because I'm going to need it as we're trying to both raise the profile of the problem, understand better what its impact has been, and really think about how do we keep our community safe going forward. Keep yourself on mute. Place questions and comments in the chat. And in your sharing, be considerate. So make sure that you are not giving us a paragraph or a treatise. Please try to keep it concise in the sharing. Confidentiality, Cambridge and Boston are very small. So if you have comments or questions that you're putting in, please make sure you're keeping your own confidentiality and that of others. And also assume goodness. We are here to share and learn and be with one another in the best of motives in all of us. And that goes for us who are putting on the event, the panelists who are sharing, as well as everyone who is joining the event tonight. So this is a map of the United States. What you see here are where the number of cases have been the highest. That deep red color and the black color are places where the number of cases are high and there are high concentrations of African Americans, Black and African American people. And so where you see in the South, those blue colors are high concentrations of African Americans with a moderate level of cases. And then the light blue is high concentrations of African Americans with low number of cases. What this points out to us is that not only are there many cases that are happening in the places where African Americans are, but also if you follow the little black dots that happen to be in places like Chicago, Detroit, in and around St. Louis, Cleveland, Washington, D.C., Baltimore, Philadelphia, New York, the urban areas that have high concentrations of African Americans are also places where there are lots of cases. This repeats itself across the country. It is also the same for our Latinx brothers and sisters, and also our First Nation Native American folks who have who also live in places where there are high level in terms of numbers of cases. This next slide is really about the Black and Latino workers are overrepresented in terms of who is an essential worker. Many of the folks who are working directly with people who are positive for COVID are Black and brown. They are the folks who are working in many of the service industries. They are the folks who are working in the the grocery stores and all the places that have remained open. But they also are overrepresented in the people who have lost jobs during this pandemic, and unfortunately overrepresented in the people who have died as a result of this pandemic. One of the really damaging pieces of this has been that in those blue spaces that you see here and in the black spaces that you see here, these are counties with high concentrations of African Americans. And in the 22% of those counties that have high concentrations of African Americans, these are the localities for more than half of all coronavirus cases and nearly 60% of the deaths. This is a pandemic that has definitely hit a specific set of communities harder than others, and we're going to be talking about why that is this evening. This is a sketch of Boston. So these are the Boston neighborhoods and where it is that they have had reported cases. The total here is 12,906. It's actually higher than that at this point. This was a total as of this weekend. 4 neighborhoods represent over 50% of the cases, and those are Dorchester, Roxbury, Mattapan, and East Boston. Dorchester by itself is nearly, almost 30% of all the cases in Boston are just in that one neighborhood. There is an unshared burden of this disease in terms of the Black and brown community, and it's something that we need to understand, explore, and start to really do something about. These are the figures in terms of race and ethnicity among Boston residents. You'll see that overall the rate is 190 per 10,000. That rate is certainly lower for Asian Americans, and as if you notice on the right-hand side, much lower for white Americans in Boston. It is very, very high for Black and non-Latino, non-Hispanic Blacks in Boston, and also high for the Latinx population. This other category is important for us to note because it includes people of multiple races, folks who wrote in Cape Verdean instead of checking off Black, folks who wrote in Haitian or Jamaican or Somali instead of checking off African American. A lot of these folks are people of color who would otherwise get counted in these two other boxes. And so what this demonstrates is a continued over-representation of Black and brown folks in terms of who is getting sick with this disease. Oops. The last slide I want to show you about Boston is who is doing the dying. And this is a really important piece of understanding this disease because, again, it is not shared evenly. At 666 deaths, 313 were in long-term care. One of the dynamics that we see true across the country is the folks in long-term care are overwhelmingly white. And so that in our communities, the balance of those deaths are in the Black and brown communities. So the percentage of known deaths as it is 35% in Boston. To the white deaths is 43%, but many of that 276 white deaths are in the long-term care spaces. Another number that I want to make sure folks become really familiar with is the number of people who are currently hospitalized and the number of folks who are in ICU. We have, as a state, turned the curve or bent the curve, but we are not out of the woods, I think is the expression that it would be. There are a lot of people who remain sick. There are a lot of people who are still getting tested, and there are a lot of new cases every day. This is just an overview of what's going on in Boston. I'm going to ask Anna if she can talk a little bit about what's going on in Cambridge.
Everybody, my name is Anna. I'm an epidemiologist at the Cambridge Public Health Department. And yeah, like Mo said, I'm going to share some of this data for Cambridge. And I just want to pause and say I'm going to show a lot of numbers. And these represent, lives and people we know and families that have been impacted. So just wanted to frame my piece with that. So this is a map of the neighborhoods in Cambridge by the number of cases we've seen in each neighborhood. And we see, so the darker orange means more cases. We see East Cambridge has the most cases in the city, followed by North Cambridge, Cambridge Port, the Port, and Neighborhood 9. And so we can see that certain neighborhoods are getting hit much harder than others. And Mo, whenever you're ready, you can go to the next one, please. One way we can compare between neighborhoods is by calculating a case rate. So the way we do this is we take the number of cases in a neighborhood, we divide it by the number of people who live in that neighborhood, and we multiply it by 10,000 to let us compare burden. And what we see is that East Cambridge, the Port, Wellington, Harrington have a much higher case burden than neighborhoods like Mid-Cambridge, Agassiz. And so when we think about where we want to send resources, we want to take into consideration where are the most cases, where are the highest number of cases, and where is the rate the highest. So that's why there's been testing in the Port and East Cambridge, and super excited. We had our first day of free testing in North Cambridge today. But it's really important to look at these spaces, like where is COVID happening in terms of where we should send testing? Because we know if there are 100 cases in a neighborhood, there are almost certainly more that we haven't identified yet. And the best way to stop this is helping people figure out, hey, who's positive and how can we isolate and slow this down. So yeah, next slide, Mo, thanks. We can take a look at our Cambridge data much in the same way Boston did by looking at the rate among different populations of folks. And the trends are pretty similar as to what we saw in Boston. In Cambridge, Black non-Hispanic folks have nearly 3 times the case rate of COVID compared to white non-Hispanic folks. It's about 1.5 times for Hispanic or Latinx folks and nearly 4 times for that other category that Mo was talking about. So in Cambridge, much like Boston, we're seeing a huge impact among communities of color, which we can see from the neighborhood maps and which we can see when we look at it across the whole city. Next slide, please. Thanks. Moa and Albert and Richard asked me to take a look at the port, looking also by gender. And I know there are about 4 bars here that look a little transparent, and that's because for any groups of people where there are fewer than 5 cases, we suppress them just to protect people's privacy. Because the smaller you go, the more likely you are to know, oh, hey, my neighbor XYZ. But the thing I want to point out is that across the city and in the port, most of the cases, or a majority of the cases we see, are among women. And as Mo said, a lot of frontline healthcare workers are getting sick. They tend to be people of color, and they tend to be women. And so in the port, the group of folks with the highest number of cases is among Black women. And that may not be that's the true number of cases, but that's who's getting tested. So next slide. So the last piece of information that I'll share about Cambridge is the death rate per 10,000. As Mo said, in many places, the majority of deaths are among our people who are living in nursing homes and long-term care facilities. And in Cambridge, much like in other places, the folks living in those facilities are majority white. And so we're seeing, a pretty similar rate among Black non-Hispanic folks, Hispanic folks, white non-Hispanic folks, which is likely driven by the high number of deaths in the nursing homes in Cambridge. About 3/4 of our 95 deaths have occurred there. But the really jarring number here is this rate of 29 deaths per 10,000 people in this category of other, who, as Mo said, are people who are multiracial, people who didn't feel represented by the other categories that we are given by the state to use. And so that's a huge impact on a lot of lives. So yes, that is our Cambridge data. It changes every day, and you can find the updated data on the city website at 4 o'clock every day, and we're watching it and keeping an eye on what's changing. So any feedback you have for us is absolutely welcome. Thanks so much for having me, and happy to answer any data questions as they arise.
All right. If you have questions, please put them in the chat box. Anna, I'm just going to ask you to make a comment about the age-adjusted rate on this slide.
Thank you for reminding me. These rates are not age-adjusted, which I know is a bit of a challenge. We haven't gotten to that point in the analysis yet. We've been, every day trying to call as many of our new positives as possible. But likely, when we age-adjust these rates, we will see a shift. That allows us to compare and control for the older white population in the deaths. And so that will allow us to more accurately compare these rates. But for now, we're using this crude rate.
All right. Thank you very much. Thank you, Anna, for your presentation. There is a question that I think you can look at in the chat box if you want to answer that one. I'm going to move us forward so that we can get to our panel. I'll click through these. So here are our panelists. I'm going to just quickly embarrass my friends by telling you a little bit about them and more than they ever wanted told to the world. So first is Dr. Craig Andrade. He is the Associate Dean of Practice and Director of the Activist Lab at Boston University School of Public Health. He is formerly the Director of the Division of Health Access at the Massachusetts Department of Public Health, where he oversaw adolescent health and youth development, school health services, school-based health centers, sexual and reproductive health program, the Office of Oral Health, the State Office of Rural Health, and the Primary Care Workforce Center. Before that, he was also the Dean of Health and Wellness and Director of Student Health Services at Wheaton College. If you can believe it, before that, he was a trained nurse and served as a critical care and public health nurse at Boston Medical Center. So not only is he a registered nurse, but he's also an athletic trainer, a strength and conditioning specialist, and a massage therapist who happens to also have a doctorate degree in public health from Boston University. Our second panelist is Claude Jacob. He is the Chief Public Health Officer for the City of Boston. That means that he runs the public health department. And so he's in charge of all of our public health. Cambridge has a fairly large public health department, and that means that he's in charge of helping us to stay safe from all the things that come into contact with the people in Cambridge. Chronic disease, communicable disease, as well as everything that happens in our workplaces, in our environment. Mr. Jacob is passionate about workforce development, accreditation, quality improvement, and health equity. He is past president of the National Association of County and City Health Officials, NACCHO, and serves on the board of directors of the Public Health Accreditation Board, as well as the Massachusetts Public Health Association. He has served as a senior administrator in the Illinois Department of Public Health, the Baltimore City Health Department, and Sinai Health Systems in Chicago. The brother comes with lots of experience in public health in spaces that look like the spaces that we are talking about with the people who we are talking about, and we've been happy to have him now for over 10 years. It is my pleasure to introduce my sister, Liz Miranda, not physical sister, my mother will get upset. Liz Miranda is a state representative for the 5th Suffolk District, including Dorchester and Roxbury, where she is from. She's in her first term there, but I've known her as a fierce community organizer and activist. She was a past executive director of the Hawthorne Youth Center, Youth and Community Center. She's worked in many social justice organizations, including the Dudley Street Neighborhood Initiative, Operation Lipstick, the Black Ministerial Alliance, and one of my favorites from way back, My Town Incorporated in the South End. She also has worked at the Boston Foundation. She served as a consultant to the Annie Casey Foundation, the Boston Public Health Commission, and worked for Associated Grant Makers. She is a leading voice in the legislature on violence prevention, guns, and police brutality, and we are so happy to have her here today. I'm going to turn it over to Richard Harding, who is going to be moderating our panel conversation. So Richard, take it away.
Thank you, thank you. Can you hear me? Everybody can hear me? Can everybody hear me?
Yes.
Good. So first of all, Claude Jacob works for the Cambridge Health Department. I know Mo meant to say that, but it seemed like Boston came through the speakers. We want to make sure that we give Claude his due because some of us have to show up at that building to work tomorrow. But first question to all the panelists, and thank you for obviously participating. So one, and we can just raise your hand and Mo will control the mute. What's your reaction to the data presented? We saw some data that showed the disparities, some very granular data, both in terms of the Cambridge numbers and the Boston numbers. So, and then I know you bring a perspective from what's happening globally in the United States around people of color being disproportionately affected by this pandemic. So whoever will do a popcorn style, but Mo will control it. Someone jump in and tell me what the data says to you in your space.
So thank you, Richard, and thank you, Mo, and thank you to the Men of Color Task Force for this opportunity. Really quickly, just want to say that what I saw from the data, and I really want to applaud and thank Anna for teeing it up. I also appreciate, Mo, how you set the tone. A couple comments. One, you saw the heat maps, the map of the United States, the map of Boston, the map of the neighborhoods in Cambridge. And so what I saw as one of the things is the commonality of the patterns. So looking at the urban centers, but zooming in to show the contrast, especially Boston to Cambridge. So that's the first thing that I noticed was just a similarity of the patterns that we saw anchored to the urban centers and just recognizing who actually lives in those neighborhoods. The other is just acknowledging something that was towards the end of the presentation. When we look at the burden of mortality, so the 95 deaths that we've had, sadly, among Cambridge residents, just know that the context, the lion's share of those deaths, 3/4 of them have occurred in the area of nursing homes and long-term care facilities. Yet, if you just look at the rate, and this is what the point that was trying to be made, that there has been this disproportionate burden, especially for Black and brown folk in the city. And it's not unique to the plight in Cambridge. So I just wanted to applaud folks for putting, and Mo and Anna for sharing that part of the story. my first comment is just looking at the similarity of the patterns that we've seen. And thanks, Richard, for making that correction. You're right. You do have to show up at some point tomorrow. And I do want to make sure that folks recognize that we are from the nationally accredited Cambridge Public Health Department. So bidding you greetings.
There you go. Anybody else? Yep.
I think it's just important to acknowledge that when we see over and over again, whether it's natural or unnatural disasters like this COVID-19 pandemic, that Black and brown people are always overrepresented. It's not just in this case, it's in Hurricane Katrina, it's in every single natural and unnatural disaster, and that is a legacy of the structural racism that started after slavery into Jim Crow and moved into every sector of this society. So the fact that we don't have equitable access to healthcare, we don't have equitable access to housing or food, or we're located in areas where we don't have the wherewithal to do all the things that people with other levels of privilege and access have, that means we are going to be overrepresented over and over again. And so this is just a long line of instances that are highlighting the disparities and inequities that are part of the legacy of this United States that includes this state in addition.
If I could jump in, Richard.
Hi.
Hi, let me see. Good evening, everyone. I want to just take a moment to thank all my friends in Cambridge for allowing me to cross the bridge virtually from Roxbury to join this esteemed panel. And I also want to take a moment to acknowledge the time that we're in. It is a heavy time. It is a time that is not new to the Black community, but I still believe we deserve to take a moment to acknowledge that there are protests and there is a lot of good organizing. And we know that racial justice is economic justice. It also is the fight for better health. So I wanted to take a moment to do that. What I know for sure is I was born and raised in a community that was environmentally unjust. We have been sick for a long time. We have already been dying 30 to 33 years ahead of our other folks who live in the Back Bay and Beacon Hill in Boston. If you live in Roxbury, you have disproportionate rates of diabetes, of hypertension, asthma. We also live in more violent communities, and the list goes on. So when I saw the data, I'm privy to a lot of things because I'm in government. Felt really strongly that communities of color were going to get hit harder. And so I pushed for testing. I pushed for us to think about this before it happened. And the rest of the Commonwealth, was saying, hey, we don't know yet. And now the data has really shown us that not only are we disproportionately impacted by COVID because of the density of our communities, because of the poverty and the overdependence on frontline jobs. Mo called it earlier essential jobs. I actually want to call it sacrificial jobs because it seems as though we have deemed people essential who we did not pay accordingly to our need of them. And they have gotten sicker because they do not have the same access to insurance and care and have to keep working to put food on their table. So, the results of what we're seeing now of COVID across the Commonwealth, many of us who legislate from Black and brown communities was saying this a long time ago, and we feel like we did it a little too late in terms of testing and getting information in the languages that was spoken by the people in our communities.
Thank you. Thank you for that, Liz. And I think that, part of the title of this, The Color of COVID, that's intentional. So if another one of the panelists wants to jump in, the next question really is, help us understand why Black folks have been in communities of color have been disproportionately suffering from COVID. We understand that in all cases, generally, the burden is not spread equally, but give us some insight into that if you can.
I'll just picking up on this thread, again, my frame of reference, as Mo mentioned, takes me back from the city of Chicago to the city of Baltimore, and now in this magical kingdom here in Cambridge. And so the common threads of what we've seen from place to place. So we hear that place matters, zip code where you live determines your life expectancy. And so just know that there are drivers and factors in these communities, which is commonplace. So specific to COVID, to your question, Richard, so we're looking at the intersectionality between race, ethnicity, and income. So that is a marker. Add to that where one lives. So the density of housing stock or the place or the physical space where one puts their head down at night. At the end of the day, we're talking about underlying conditions. Again, to what Dr. Andrade just mentioned at the outset, there are these factors, the morbidity that we see, tried to chronic diseases, tried to the transmission of communicable diseases, and as it impacts our communities. And so I would just say that there's a constellation of factors. It's not linear. It's not just one piece, which means that as we talk about the different drivers or the different determinants of health, there may be an opportunity for us to lean in a little bit more. So it's about the different policies that impact the quality of life of our residents. And so at the end of the day, this gives us a snapshot to Representative Miranda's comment about early in the process. So even testing, I would say that one of the biggest challenges tied to the COVID storm is the speed at which all of these things are changing. So the guidance from the CDC has changed. The guidance from the state has changed. Just the numbers, the case count, that keeps changing daily. And so it's been a moving target. It really impacts our communities. But at the end of the day, this is an opportunity to at least pause, take a look at the information that we have, but recognize that this is tied to a long history of institutional and structural racism, which continues to impact disproportionately our communities.
It's worth saying that people are overexposed in part in Black and Brown communities because if they don't have sick time in their jobs, many people that are working in any number of essential jobs that they have to go to no matter how they feel, because if they don't work, they don't get paid. If they don't get paid, they don't eat, they don't have a place to live. And so while we may have essential jobs, our workers aren't being treated as if they're essential because we're not making sure that they have a living wage. They need to have sick time and paid leave as an overarching kind of mandate, no matter what kind of job you have. If you're working in a Burger King or in a hotel as a cleaner or a janitor, or if you're working in an area where you have to be sure that you show up every single day, and if you don't, you can't afford, you don't have sick time. That is just one of the core elements of why we're overexposed as Black and Brown communities.
Good, and I appreciate that kind of perspective. Claude, to you, can you just help us to understand, what people should be doing to protect themselves and their loved ones? From you and I talking, since this started, I've expressed to you my concern that, some folks, some younger, definitely other folks of color, just aren't taking it serious. And so can you just speak to, what people can do to keep themselves safe and their family, kind of from a prevention lens, but also understanding that, for most people, we've never been here before.
Yeah, thanks, Richard. I'll tee it up and others will weigh in. So thinking about dispelling the myths, again, early on, at least, and I can tell you as an islander, what I had heard, at least in my family circles, folks were talking about, well, we don't fall prey to that. This is early on. Not just, again, what was happening in the Haitian community, but I would say that there are myths and misnomers out there. Mo shared the first slide about the things that we could do, that we can continue to do, tied to hand hygiene, wash your hands, just making sure that that is a basic tenet that we've been encouraging folks, 20 seconds, sing the happy birthday song, do all those things, but making sure that you continue to wash your hands. I would just underscore the 12 times a day. That sounds like a lot, but hey, think about it. Once an hour over the course of the time that you're awake. I mean, that's easy to do. But at the end of the day, it's also about the current culture that we're in, about masking up. I mean, really, why do we do this? It's shaping the culture. We're talking about protecting you from me and me from you. And so it is something that is now catching on a little bit more. Quite frankly, there was a little bit of confusion at the outset. The guidance from our federal partners, do you go after a mask? Do you leave the mask? Do you leave the mask for the healthcare workers, just know that now that is something that we are asking. You see enough ordinances and regulation and requirements from city to city and state to state that remind folks to wear a face covering or a mask. The only other two things I would mention is that the COVID fatigue, the isolation fatigue, the quarantine fatigue, that is real. And so however one can manage that space, however you can find that outlet, we would just underscore, again, the importance of taking care, not just of your physical health, but also your emotional health. But the number one characteristic that I should mention, which is probably the hardest thing for us to do, given that our nature as human beings, is literally to be physically distant, physically apart. This 6 foot, this 10 foot, I mean, that from the outset has been the hardest message to get to folks. Think about it. Anyone who's an athlete out there or wants to get together and so whether pick up ball or play any other sports, the first thing you do is you want to get together. I mean, soccer to the Islanders, that's a popular sport. It is a contact sport. And so the challenge with sharing this with folks is that, yes, there are misnomers. Yes, we're reminding folks to wash their hands. Yes, we do ask that you mask up. But at the end of the day, managing your emotional well-being while making sure that you stay and maintain those social distances, that's really all that we can do. And we're asking folks to help continue to get that message out in the community.
Anybody else want to take a stab at this one?
It's important to acknowledge that there are some people that just have no capacity to social distance. If you have multiple people living in the house that are all working and going and exposing themselves to multiple people by the nature of their job, and they come back and they're not able to be in separate rooms and separate places, they're going to be exposing themselves and their family over and over again, and they unfortunately have little choice. And then we have to think of the homeless that don't even have the capacity in many instances to wash their hands, never mind 2 times a day or 12 times a day. They just don't have the resources to do that, and they are challenged in that way. So that I often push back around the kind of people are taking this seriously. Some people may not be, but there is also people that just don't have the wherewithal that we just take for granted.
And I'll jump in here. Thanks to both Craig and Claude for saying some very powerful things. And I'll just take us back to March. And when March happened, many people were looking at the news. Folks were giving guidance to the man, the occupant of the White House, like Ayanna likes to say. And he was saying that we didn't have a problem. By the time he said we had a problem, a month had passed by or 2, and then they said that this was impacting elders in our community. And so there was a specific group of people that folks were worried about. When the next guidance came out, it was like, it's impacting actually other people. So by the time April came, and I know my family was deeply impacted, and I'll talk about it later, I was watching the news and they were saying, this poor doctor has to sleep in the upstairs wing away from his wife and his kids. And, I really respect that doctors are working incredibly hard. And I was thinking to myself, with the triple deckers and the apartment buildings in my community, in some households, there are 15 to 20 people living in one home. And we know that we want to talk about the homeless community, and homelessness has been on the rise. People just didn't have access to sanitizer, to masks, to the type of soap. Kids were home from school, so things were getting used all the time very quickly. And we had residents calling me on a daily basis saying, I know what you're saying on the news and online, but it's not in my language. For example, Portuguese and dialects of Portuguese are the number 2 spoken language in the Commonwealth. And it took months for language to be translated. Here in Boston, and I know Cambridge, we have a high sensitivity to language access. But if folks lived in other towns, like Randolph or Stoughton or Brockton, they didn't get access to the adequately created information so that they could understand what was being shared to them. And then cultural norms. In many of our communities, we get together with our family as a way to build community. And so therefore, when you're sharing with someone to be distant, it was very foreign to them. What do you mean I can't go play cards on a Friday night? I'm not going to get sick. I'm healthy. A lot of the data has shown us that asymptomatic people have passed COVID to their family members and friends because there were symptoms that people were supposed to look for that they did not have. So when you're talking about how do we keep us safer and healthier, I feel one of the shames of being in this role is that we have once again put the burden on those impacted and inflicted to solve their own societal ills. I think this is a moment where public health, the health systems, the hospitals, and government have to take onus that we have to do better to make sure that our communities can help themselves, because we have not created the space for them to be able to do this quickly and adequately. Now we have testing in our communities, but for months we did not.
No, and I appreciate that. There's many levels to this, and I appreciate you talking about all of them. Why don't we jump back to Craig? Craig, can you tell us a little bit about, you often hear, pre-existing conditions, comorbidities, all the other factors that may play into why communities of color were hit hardest. Can you talk a little bit about why has it been so damaging, the pre-existing conditions to Black and brown people and people in general around COVID-19?
Sure. So, not long ago, when we talked about people who had pre-existing conditions, chronic conditions, for example, obesity, asthma, hypertension, cardiac disease, these were considered conditions of behaviors. These are conditions that people are having in higher rates in Black and brown communities because of the environments that they have lived in. We all have some agency in our personal responsibilities, and more people in Black and brown communities have less choice whether or not they can walk down the street to exercise safely, whether they can get access to healthy foods. The idea that for many people, the cheapest food is the less healthy food. There's where there's higher rates of obesity in our Black and brown communities. Hypertension, the stress that is the long-standing stress of everyday racism that happens in our communities is part of the legacy in our communities from generation to generation. And so these rates are not because of personal responsibilities, it's because the places we've been forced to live in, the places that we've been have less access to safe environments where we can exercise and be in less stressful spaces, the ability to be able to get a job that allows you the resources to make sure you have adequate health insurance. All these things are pre-existing conditions that are legacies in large part because of the infrastructure and structural racism that are embedded in the healthcare system, the education system, the policing system, the housing system, and on and on and on. Many of us that are presently have generations that have lived in these neighborhoods where it is more difficult to get adequate transportation to our jobs, and on and on and on, is a legacy of redlining that made sure that we couldn't be in one neighborhood, but we could be in a different neighborhood. So I, after 14 years working as a nurse at Boston City, then Boston Medical Center, I watched over and over again these consistencies of people that had these conditions. We sent them back to an environment that didn't allow them to maintain the healthy environment that they were able to get once they got past the acute care that they needed in the hospital. They went back and they came back into the hospital over and over and over again. So this is a challenge that is not an individual responsibility. It is policies, practices, and ways that we manage our communities across this state and across the country that have deep lines to where we are and why we're more greatly impacted by things like COVID-19.
Yeah, thank you. I so appreciate that. Claude, do you have something to say on this?
Just something that Craig just mentioned reminded me of just the history and the legacy of the work of the Men of Color Task Force here in Cambridge. So recognizing that long ago, imagine 30 years back, when there was this issue with how African-American males felt comfortable or accepted by the healthcare system. And so I say that to say that part of the history and part of the way that we've been trying to address not only the the institutional and structural racism is making sure that we bring to light the issues of the plight of folks of color in the city and across the Boston metro area. So I just wanted to acknowledge what I know of the work of the Men of Color Task Force. Clearly, we've tried to have more boots on the ground, anchored to what we now do through the Men's Health League in partnership with a lot of folks from across the city. But something that Craig mentioned in terms of the history and what we try to do to at least mitigate some of those conditions by virtue of having other ambassadors on the ground to share at least the reality of how these situations are impacting, especially men of color in the city. So just wanted to at least connect those dots tied to at least one demographic here in the city.
Yeah. Liz, you want to jump in and talk a little bit about your experience and, you're dealing with, the COVID-19, you and your family's experience. It'd be helpful to give us some insight. And we're so glad that you are a survivor.
Thank you. So in March, my grandmother and my father both got sick. They both were tested for COVID and they both received negative results. My grandmother then came home and my father remained hospitalized. He has COPD. When you talk about all those contributing factors, he has heart disease, he has diabetes, and he remained in the hospital. Although the hospital was deemed not a safe space, he could not be home. And in a matter of 2 weeks, my grandmother declined severely and sadly on April 17th passed away. And our family, being that we're Cape Verdean American, it was very hard at that time to say to my family that they could not spend the last week of her life with her. We received a negative result. We thought that she had just passed away because of her dementia. Although I kept fighting my family to really say, grandma was pretty good. I don't believe that this test was a negative. I really think that she might have had a positive because her sharp decline into hospice care was something that I did not expect. Now, I'm glad to be alive, but my grandmother raised me. I feel like my family has sacrificed and lost someone that we now know actually had a false negative, who was sick. After my father returned from the hospital, actually on the day of her funeral, we noticed that we probably were getting sick. One of my uncles was coughing. My dad had just returned from Mass General. We know that returning from a hospital, he was not tested again. And in a matter of 5 days, my dad was back in the hospital and we got a response from his doctor that he was sick at the end of April with COVID-19. Now, this is where the story takes a turn. By now, at the end of April, Bowdoin Street Health Center, Dorchester House, and Upham's Corner Health Center, which are the three main community health centers in my community, had started doing testing. Now, they had only started doing testing for two groups of people. Had you been exposed and had symptoms, and were you a patient in one of those hospitals? Now, if it wasn't for my position as an elected official and also being someone that was very connected to my community health centers already, I would not have been able to navigate the testing opportunity for me and my family. I was able to work with the executive directors of most of those facilities and said, hey, we've all been exposed. We need to go to the hospital and get tested. Can we split up the family and our neighbors who came to pay their respects to my family very quickly? And if it wasn't for the leadership of those organizations who understood that we needed to get everyone tested quickly, we would not have known in 24 hours that over 20 people in my family actually had COVID-19. And it was dreadful. Many people in my family had severe fatigue, started to lose their taste and smell. Folks had severe coughs. Some folks had pneumonia. I could not get out of bed for 4 days, and I am a healthy 39-year-old. And I really thought for a moment there, I was not going to only lose my grandmother. I was going to lose my dad, who was in the hospital now on a ventilator. I was going to lose my mom because she had diabetes, and I was possibly could have lost my life because I had never been so paralyzed in terms of sickness for those days. And so my story is one of many stories. I could not, my title didn't shield me and protect me from COVID-19 because I am actually in the Blackest district in the Commonwealth and one of the poorest. And so for me, I was trying to share my story once I got better. And thank you for sharing it today, for allowing me to share it, because I want folks to know that we are still sick. And when we get sicker, we get it worse. And I'm glad that my family is well now, but I'm still thinking about that dreadful day and where we buried my grandmother, and thinking how many other families lost elders and loved ones in their families.
Thank you for sharing, Liz. I think that it's critically important for people to understand the seriousness of it. And I know that, I remember when I heard that, you got it, it really hit home that, this disease, doesn't care about boundaries or timelines. It's an opportunistic disease. And so we're so grateful to have you with us.
And I'll add age, my family, a 2-year-old was sick and a 78-year-old was sick. And so it's important to, when I shared my story, was that it's not an older person's disease only. This is a viral infection that was impacting people of all ages. And I think some people took it very seriously after me coming out to share that we needed to stay protected. And I followed almost every protocol, besides my uncles being there when my grandmother took her last breath. We had sanitizer, we had masks, we tried to distance ourselves. And so it was important to share that story.
Yeah. Craig, thank you, Liz. Craig, can you jump in just to talk about, what we need to strengthen the system for the next pandemic that comes up? It's interesting. Claude and I we were catching up last evening, and the question was, people are, while some people aren't taking it serious, people are also in the know that this thing could come back, or some pandemic could come back. So what can we do as communities of color to strengthen the system, health system, other systems for the next pandemic? As you talked about the ones previous before COVID, what can we do? What's your advice?
Have to take stock in the fact that we are living in a state that takes public health and healthcare seriously. I, having been in the Department of Public Health only just a little while ago and there for many years, I saw firsthand how hard everyone was working to try to make sure that they would cover their bases. This is a new disease, and we learned a lot of lessons in this, and we know how to do better next time, and we're continuing to do better in this state. We are fortunate to be in a place like this where we have a governor that's taking us seriously, and it's not perfect by any means, and then at the same time, cautious, steady state. We just, on Sunday, the governor signed an act to address COVID-19 data collection. Up until just a little while ago, we haven't been collecting race data on COVID-19. And therefore, we acknowledge that Black and Brown communities are being hurt disproportionately, and in deaths and in number of cases, and lack of access to preventative masks and all kinds of other things, not having language to be able to reach our people that don't speak English as a first language, our immigrant population. All those people, we need to think of how do we center from the margins and make sure if we can do it well for those communities, we can make sure that every person in the Commonwealth is better standed off. The Mass Public Health Association has been trying to make sure our legislature and governor, our government is held accountable in all the things they do in the midst of the hard work they're doing. So the idea in the future that we have emergency paid sick leave for everybody. One of the things that the Mass Public Health Association is still urging to move forward, that we have safe quarantines for people that are experiencing homelessness, that we collect reporting data in all races and ethnicities so we can make sure we know where the hot spots are now. And if we have hopefully not another wave. We know where it's landing, and making sure everybody has access to testing. If we think of the most invisible people, think of our brothers and sisters that are in jails and prisons. When people are in prison and they are near the end of their time and they're in high risk profiles like over 65, we should be making sure we can find safe ways for them to get out of jail if they're not a danger to society, so that they can take care of themselves and not make prisons another hot spot and jails another hot spot. And making sure that the state has standard of care insurance to be sure when they're doing everything that equity is on the table, and every single policy and procedure that we put on the table, that we're thinking first about our least access, those with less privilege and less resources, that we start there and then work into the majority that have higher levels of access and privilege.
I appreciate that. Claude, you want to jump in? We know that unfortunately, because of COVID-19, we made the responsible decision, I'll say, to postpone the Hoops and Health event, which is one of our standard bearer events in Men's Health. It also is a culminated event for Men's Health Month. Can you talk just a little bit about particularly Black men and men of color in particular as it related to the COVID pandemic? We know that, I said this to Mo and Albert a couple